So what I'm going to, you've seen that the last three talks have something in common. They're focused on pyrophosphate metabolism and an alkaline phosphatase as part of the pathway. Well, I'm going to convince you that alkaline phosphatase is a crucial pathogenic event in the calcification of the arteries, in medial calcification. And I'm going to show you our path towards developing a therapeutic approach to inhibiting ALK-Phos, thus elevating pyrophosphate levels back up in the vasculature to preventing and reversing this condition. A lot of what I am going to show you has already been presented, so I'm going to go quickly. Indeed, I'm talking about medial vascular calcification, not atherosclerosis, very different pathogenic mechanisms here. And of course, GASI, we've heard a lot about. End-stage renal disease is a major problem for this disease. Diabetes, obesity, perhaps even Kawasaki disease, and aging in general. This is, as to quote Dwight Towler, an underappreciated epidemic in terms of the severity of medial vascular calcification. So let me go back to what alkaline phosphatase is doing, or how pyrophosphate metabolism is regulated. In the biology of skeletal mineralization starts within matrix vesicles, which are these small bags of enzymes that are bleeding out of chondrocytes. And what happens in that milieu is that you have the initiation of calcification. Calcium and phosphate come together. But they have inorganic pyrophosphate, a very potent inhibitor of this process. And that inhibitor is present throughout. Once calcification proceeds outside of matrix vesicles, essentially the membrane of the matrix vesicles disintegrate. You have now mineral onto the osteoid, onto the collagenous matrix, and it's always calcium and phosphate together, the ratio of phosphate to pyrophosphate that needs to be controlled in order to have proper calcification. And that's what this slide here tries to indicate. Sorry, the mouse is not showing here. You need to be in the green zone to have controlled calcification. If you have too much pyrophosphate, you have the disease hypophosphatasia, which Michael White will refer to in the afternoon. If you have too little pyrophosphate, you have arterial calcification. And that's what has been already shown by Dr. Rush. And this is very similar to what he showed. We have NPP1 or PC1 producing pyrophosphate from ATP enzymatically. We have the ankylosing protein transporter transporting intracellular pyrophosphate to the extracellular milieu. And we have tissue non-specific alkaline phosphatase, whose main function is to cleave inorganic pyrophosphate, destroying this inhibitor of calcification, and thus regulates the extracellular pool of pyrophosphate, which is quite crucial. Hypophosphatasia, just briefly, what happens is that a deficiency in alkaline phosphatase, you have accumulation of extracellular inorganic pyrophosphate that causes the hypophosphatasia phenotype. More on that by Michael White this afternoon. And if you ablate the enzyme that produces pyrophosphate or the transporter of pyrophosphate, you have a very similar phenotype. Low extracellular pyrophosphate, ectopic calcification, enthesopathies, soft tissue calcification, including intervertebral disc calcification here, both in the NPP1 and ANC model, very similar symptomatology. You have calcification of the arteries. They develop very slowly, up to 6 months in the life history of these mice. You can accelerate the process with high phosphate diet. However, let me show you that the calcification is very spotty. Here is a fly through the artery of one of these NPP1 mice, and it's very spotty calcification. It's not really massive like you can see in some of these kids with GASI. And certainly in these mice, we don't have the cardiac hypertrophy that is characteristic of some of these patients. So I'm going to show you later that we have developed now a very nice model of GASI, much more robust than NPP1, which is a natural model of GASI. Some time ago, we studied NPP1 deficiency and ANC deficiency to make an important finding. That is that what was common to these two models was upregulation of alkaline phosphatase in the vasculature. We cultured vascular smooth muscle cells. We saw that they hypermineralize, and we saw a doubling of TNAP activity essentially in vascular smooth muscle cells. We also look at uremic rats here on the right side. So this is a 5/6 nephrectomy model of end-stage renal disease. And again, those arteries have high levels of TNAP compared to wild-type controls by Western blot. So TNAP upregulation seemed to be a crucial pathogenic event in medial calcification. And going back to the literature, you see here that diabetes has TNAP upregulation in the third bar. End-stage renal disease, TNAP upregulation has been shown. And then in the syndromes we talked about this morning, coital syndrome, GASI, ADCS, DC, PXC probably, although that has not really been looked at. But so all of these have a common denominator. Upregulation of tissue non-specific alkaline phosphatase causes a sinking of pyrophosphate levels, and that is what triggers vascular calcification. So our stance here is that upregulated TNAP is a crucial pathogenic event, and we are committed to finding inhibitors, pharmacological inhibitors of TNAP as a way of modulating pyrophosphate concentrations and preventing this from happening. So most of what I'm going to show you now is still unpublished, is the work of an excellent postdoc, Campbell Sheen, who has remarkable data that I will show you now. What he has done he has inserted the TNAP cDNA, the human TNAP cDNA, into the HPRT locus of mice. So essentially, we're generating now an X-linked disease here. This cDNA is flanked by LOXP sites. So these transgenic mice are normal until you breed them with a mouse expressing Cre recombinase, able to excise those LOXP sites and now activate expression of the TNAP cDNA. We've done that by breeding them to the tag-linked Cre mice, which express essentially SM22 alpha actin. So it's a vascular smooth muscle cell specific promoter. So only vascular smooth muscle cells will now activate TNAP. And what happens? You see here histochemical staining on the left for alkaline phosphatase associated with massive calcification in the medium. You see here alizarin red staining for those massive deposits. Here is von Cossa staining, both in the ascending and the descending aorta. Massive calcification. This is 30-day-old mice. So very quickly after birth. Look at this change in gene expression. These are aortas taken right out of the mouse, homogenized, extracted RNA, and done qPCR. Massive, essentially, turning on of chondro-osteogenic program right out of the mouse. Essentially, 30-day-old 14 and 30-day-old overexpressing aortas, and you see mouse alkaline phosphatase going up, RUNX2 going up, phospho-1, osteopontin goes through the roof, collagen-1, BMP2, PIT1, MPP1, ANC. All of these markers are going up immediately in just taking the aortas right out of the animal. So this, to me, indicates transdifferentiation happening in vivo. This is the X-rays. You don't see much at 7 days. At 14 days of age, you see already mineralization of the aorta, and 30-day-old is really a solidly calcified tube. And this video here requires no further explanation. 30-day-old mouse sample, fully calcified aorta. You'll even see the heart valves calcified up there. Some cross sections that show the ascending, descending aortas, essentially a whole ring of calcification. And what happens to these male mice, which essentially are hemizygous for the mutation? Very, very quick death. Essentially 2 months after birth, they die of their disease. And what do they die of? Well, look at their heart sizes. Tremendous heart hypertrophy. And you see already at 14 days, you see the different sizes. 30 days is very clear. With the help of a fantastic team at the cardiometabolic phenotyping core unit of the Sanford-Burnham, we've done some physiological studies on these mice, and they've essentially been able to use the Vivo 2100 to look at some parameters of cardiac function. Here I'm showing you that the left ventricular mass index is very much altered. Here we compare male mice, 28-day-olds, with female mice, 28 and 56-day-old females. You already see that females tend to live longer, and I will show you some graphs to that effect. But essentially, we have changes in ventricular mass. And here in these videos, you should clearly see how the 2D echocardiogram is abnormal in the 4-week-old male mouse compared to the female mouse, aberrant or affected cardiac function. Look at hypertension. It is a case of female mice are easier to catheterize, so easier to do these measurements than male mice, which male mice you essentially have a solid tube, calcified tube, very hard to put needles in. But here you see the pulse pressure in a gassy female model is 88 milligrams mercury versus 28 in the control. Is this moving? Okay, are we stuck? Okay, so this is the rate of calcium deposition compared to heart weight. Both males and females, they have a little bit different rate of development of the cardiac hypertrophy associated with calcium. And evidence of myocardial calcification and necrosis. You see here male mice, very hypertrophic, evidence of necrosis, voncosa, and H&E. And here is a slower rate of buildup in females. You see that at 195 days of age is clearly evident, but not so at 1 month of age, where males were severely affected already. And that is associated with the levels of alkaline phosphatase overexpression. You see that male mice at 14 days have 4 times the levels of ALK-Phos in the plasma. At 30 days, 22 times the levels of ALK-Phos in the plasma, while females at 150 days, 150 have only 12 times. So the levels of ALK-Phos correlate with the severity of the disease in this model. And you see the survival of females, 180 days and still going. So very different survival rate compared to the male. So we have essentially a very robust model of GASI in male mice, a less robust model of medial calcification, perhaps similar to what you might see in end-stage renal disease. This will allow us to explore the therapeutic benefit of the therapy we're trying to implement, and also look at side effects in bone of growing mice, in male GASI mice, and in bones of adult female mice, to see what possible side effects, if any, we observe with the treatment. Clearly, we're targeting an enzyme that is important for skeletal mineralization as well as vascular mineralization. So that is a primary concern that we need to address. So this is where, I don't know how to silence that, but this is where our team of chemists at the Sanford-Burnham have come into play. They have been wonderful, helping us identify hits and turning them into pharmacologically drug-like compounds. And we did a screen about 3-4 years ago. We identified some aryl sulfonamide derivatives that were good at inhibiting calcification of vascular smooth muscle cells in culture. They also were good at diminishing the calcium load of aortas ex vivo. However, we got stuck because of poor pharmacokinetic properties. They were not very soluble. They had plasma shift issues, all the issues that our chemists are able to deal with, and they did so. They went through structure-activity relationship studies, turning a poor compound into a good pharmacological compound by a number of substitutions and so forth. Several iterations of screening and testing of the derivatives, and essentially they turned what it was a poor compound, ML28, with all the red indicates those parameters that were not optimal, turning them into green parameters. And you see, for example, exposure, you go from 1,000 to 84,000, microsomal stability, good IC50, etc. They tell me that you go, essentially, this represents a 1,000-fold improvement in the pharmacokinetic properties of this compound. So we also used endogenous TNAP, plasma TNAP, as a biomarker for efficacy. We can actually titrate the level of drug in the plasma by looking at residual levels of activity in the plasma. They developed essentially a 100% plasma assay, so you do not have to dilute your sample. You essentially measure residual activity in 100% plasma, where the inhibitor is there at full potency. Very important for our purpose. So these are some efficacy studies that we're doing. They are still ongoing. We see here that the calcium load and the heart size are diminished in female mice. This is statistically significant. We are improving heart size and decrease the calcium loads on these females. We're also doing the same with males. The degree of correction is less clear, but it is happening. And what is happening more importantly is that the males are surviving longer. And here I'm talking about a single dose of 10 milligrams per kilogram per day daily from 7 days of age up to the termination of the experiment, which is probably not at the optimal dose, but we're increasing the survival of these severely affected male mice. So that's where we are. We essentially have an optimized lead. We're trying now to get done the studies that are needed for an IND approval to go into clinical trials with this experimental approach. And we're seeking to partner with pharmaceutical companies to be able to do the tox studies and the IND enabling studies that are needed, which are beyond of what we can do with simply grant support in our laboratories and one postdoc on the project, as you can imagine. So possible clinical uses for this approach? Well, certainly GASI. Given the success that we've had with Michael White, Inobia, Alexion, on treating hypophosphatasia, rare disease are a wonderful way to enter a market because approval for an orphan indication is much easier, faster, if you wish, than, for example, going directly for chronic kidney disease, which clearly would benefit a lot more patients, but it would be much more difficult to perform in terms of clinical studies. Heart valve calcification, I think, is another area where this therapeutic approach could have an influence. Heterotopic calcification, something that Eileen Shore is going to discuss today extensively. Perhaps Kawasaki disease. We have also experts in Kawasaki disease. So all issues of arterial calcification or inappropriate calcification could be dealt with potentially with a TNAP inhibitor. And these are some of the incidences of these conditions, which you know better than me. So with that, I'm just going to close and thank the granting agencies, of course, mainly NIH, but also an internal Finnish line fund that has helped push our chemists to bring a compound from a scaffold to essentially a drug-like compound. So thank you. Michael.
The alkaline phosphatase, do you see any change in ENPP1 or ANK expression?
Right now, we're concerned about just are the mice living? Are we looking at calcification improvements? We haven't looked at those kind of parameters in plasma or in cells in culture. So more to come. Yes, Mark.
That the female mice are really protected from the disease because they're making less alkaline phosphatase, or because they're inactivating, I assume they inactivate on one of their X's,
Right.
the transgene,
Right.
and that the phenotype is cell autonomous, and the transdifferentiation that occurs can be prevented by some sort of paracrine signaling, so that the cells that were lucky enough to turn off the right X chromosome are not going to transdifferentiate and are going to make some factor that keeps their neighboring cells from transdifferentiating, even though the other cells are not so lucky.
Well, interesting question. My quick answer would be clearly the females are mosaic in expression of the Cree. So that in itself explains. This is essentially an X-linked disease, so the females were expected to have a milder phenotype from the let-go. The fact that severity correlates with levels of alk-phos, yes, I would say that 12-fold increase at 150 days is less severe than 22-fold increase at 30 days. So I think the degree of sinking of pyrophosphate has a lot to do with how much transdifferentiation you get. But getting at the issue as to some cells may or some, we have not looked at that particular issue. Yeah, but that's an interesting question. Please, Tom.
Had a chance to see if these animals phosphate waste, have low blood phosphate?
Samples are being collected. I mean, these experiments are running as we speak. We have not yet looked at urine levels of any parameter, but the samples have been collected. I don't know yet.
José, great talk.
Thank you.
So related to what Matt was asking you, if this drug has to have application for other diseases, such as heterotopic calcification, have you determined whether it's blocking transdifferentiation? Is it blocking transdifferentiation? Two, what happens when the mice eventually die? So are you simply delaying transdifferentiation, or you blocking mineralization? So I think you know what I'm asking.
Well, to answer the second question, I think what is happening is that we are reducing probably reducing hypertension, reducing calcium loads, preventing the hypertension, and preventing the probably sudden death, cardiac sudden death, which is the cause of death of these animals. We have not yet looked at whether we are now reversing transdifferentiation. We are just trying to optimize this treatment. Eventually, we will have to go to ex vivo cultures to look at what is happening. And again, with treatment, take the aorta out, look at gene expression, has that gone down or not? This is for the future to do, but good question, yes. Yes, please.
So how come this drug is thought to affect tissue non-specific alkaline phosphatase in the bone and not just all over the place? like in the circulating alkaline phosphatase?
Well, we do not know if the levels that we are now obtaining therapeutically do or do not affect bone. We are collecting now bone samples. We've done the calcium labeling, all of that, to look at apposition rates. We are, of course, concerned about causing teratogenic hypophosphatasia, since that is the other disease we work on. But I think it's a matter of dosing. We can get a dosing right for vasculature and not for bone. There was another aspect to your question. Okay. Yes? Yes, please.
Do you think that this system would also work for ENPP1 deficiency? Because I think it's a little different, because you don't know in ENPP1 deficiency you have also deficiency of ENPP1 in plasma and maybe also in smooth muscle cells. Do you think this will also work?
In fact, that is the experiment we are going to do. We have the NPP1 knockout mice, which we have studied for several years now. The next trial is going to be, can we reverse this now in a natural, recognized model of the disease? This is, in a way, a little bit artificial. We're really boosting ALK-Phos to the maximum here, generating a very robust model, but a model that mimics the cardiopathology that the NPP1 mice don't have. But can we inhibit TNAP activity in the MPP1, as well as the MGP mice that Herbert discussed? These are things that are already in the plan. So yes, we do want to validate this in a couple of other murine models that appear to all converge to a TNAP upregulation. Okay, time for lunch. So please enjoy yourselves. There should be tables set outside for you to enjoy the Southern California sun. So, and we'll reconvene on time. Thank you. 12:30.